afternoon. Thank you for attending our Season 6 finale of OCHIN Grand Rounds. I am your host, William Pinnock, and today I could not be more excited to welcome Dr. Nathalie Huguet of Oregon Health and Science University as she presents What Did the Affordable Care Act Do for Community Health Centers and Their Patients? Dr. Nathalie Huguet is an associate professor in the Department of Family Medicine at Oregon Health and Science University, who has been published in, to name a few, the Annals of Family Medicine, Implementation Science, Journal of the American Medical Informatics Association, and the Journal of the American Board of Family Medicine. She is a health services researcher and implementation scientist with a focus on improving access to and delivery of primary care services among vulnerable populations. She is the multi-PI and co-director of the Bridge C2 Center in Implementation Science. This session is being recorded. Attendees are muted upon entry, but if you are not, please mute your microphone and pose your questions through the Q&A or chat box. This presentation will last approximately 45 minutes with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Nathalie Huguet for What Did the Affordable Care Act Do for Community Health Centers and Their Patients? Dr. Huguet, the floor is yours.
Thank you, William, for this lovely introduction. Season finale, that's special. Whether or not I will end with a cliffhanger, that's to be determined. Good day, everyone, and thank you for joining. I'm happy to share with you today multiple results from many studies assessing the impact of the Affordable Care Act on patients receiving care in community health centers. It would not work. There we go. I have no conflict to disclose, and me and others in the team have received funding from multiple agencies to do this work. So the learning objectives for today is for everyone to better understand the impact of the Affordable Care Act on access to and delivery of care, is to consider the opportunities for policymakers around health reforms, the pre-existing conditions, health equity, especially in today's climate, and lastly, to explore which patients may need additional assistance or outreach based on what we've learned. So just in case you forgot about the ACA, as there are so many other important elements and events that have happened since, the Affordable Care Act was a very large healthcare policy. And this type of large policy can have a wide and multi-level impact. For instance, the Affordable Care Act was supposed to help patients get insurance, which in turn would improve the health of the patients, which could improve population health, at least in theory. You could have a policy targeting a health system that impacts burnout in clinicians, for example, with a snowball effect on patients, and then the health of a community, again, in theory. Important to keep in mind is that the impact of a policy can have unintended consequences that can affect any of these different levels. So it's also very important to evaluate all of these policies, like the Affordable Care Act, and to look at it at different level and on multiple outcomes to really figure out what works and what does not work and what might need to be changed or adapted. So why are we studying this policy? Well, one thing is that we really want to know whether it was implemented correctly or as expected, and equally or similarly everywhere. So that is referred as fidelity. You want to make sure that all the different provisions were implemented everywhere equally, which we know that did not happen. This is important because if the policy is not adopted in the same way across, say, different clinics, for example, then the impact may be unequal for these different patients. We also want to make sure that the policy has the intended result. That is, if a policy is aimed at improving insurance access, like the Affordable Care Act, we should see fewer uninsured patients. And it's important to study and learn about these unintended consequences of that policy, whether they're positive or negative, to inform adaptation and changes to it. And that applies to the Affordable Care Act or any kind of changes you make locally. So if a policy is aimed at fixing a problem, for example, health insurance, and end up creating a new problem, like say the popularity of high deductible health plan, then maybe we need to figure out how to change that. Here's a quiz for you. So I have several of those throughout. Put your answer in the chat if you want. There's no prize at the end. This is just for fun and to keep you occupied while I'm talking. What do you know about the ACA? Which one of these provisions is not part of the Affordable Care Act? I'll give you a few seconds to think and answer. And the answer is, excuse me, no, that's not the answer. C, the answer is C. Technically, the ACA did not specifically set cost control for medical procedures, though some of the provisions aimed at improving or targeting healthcare costs. All right, let's look more specifically at the ACA and refresh our memory. Obviously, the most common known provision is to improve access to insurance via either the increased eligibility for Medicaid, allowing adult children to stay on their parents' plans until the age of 26, and creating health insurance marketplace. But the ACA also had some protection against healthcare fraud, improving healthcare quality, ensuring mental health care parity, removing out-of-pocket expenses for preventive services, and protecting patients with pre-existing conditions from being denied health insurance. So it was a full package that was trying to address access and cost barriers, improve preventive and mental health care, somewhat control the care of cost, and reduce disparities. Well, as you know, expanding Medicaid eligibility was contested and became a state decision. But do you know how many states have expanded Medicaid as of today, July 2022? Put your answer in the chat. Here's the answer. As of July 2022, and it's been that way for a while, 39 states, the blue ones on this map on the left, have expanded Medicaid to some format. Wisconsin, for example, is not blue, but they did expand eligibility to 100%, which is better than zero. Back in 2014, at pretty much the start of the ACA Medicaid expansion, only 27 states had implemented Medicaid eligibility expansion. And this differential adoption allowed us to not only study the impact of the ACA overall, but to have this control group of non-expansion states, these orange states, when it comes to studying whether or not expanding Medicaid was beneficial. This is a really great design. It's called a natural experiment design, and it's much stronger than just doing pre versus post. So what did we study during all these studies with all that funding? We evaluated all of these elements, such as access to care, looking just at insurance coverage. Obviously, we're going to jump on that. Preventive and mental health care. We also looked at the economic aspect and evaluated healthcare spending. And we also looked at whether or not the policy addressed health disparities and improved health equity. How did we do this? Well, we compare changes in all these different outcomes pre versus post ACA. For example, number of visit pre versus number of visit post. But that's not quite a great design. So since we also looked at state that expanded and state that did not expand, we could compare whether these changes were different in the state that expanded versus the state that did not expand Medicaid. We also compare some of these outcomes by looking specifically at patients who gain insurance and look and compare them to those who either were insured throughout a long period of time or remain uninsured throughout a long period of time or were churning. So for these studies that I will be presenting, We use data from community health centers, mostly EHR data from the advanced CRN, which is led by OCHIN, and include both the OCHIN network and the Health Choice network, which then covers many, many states across the US and provides data on many community health centers. We typically use a two-year pre-period to assess what happened before the ACA and either 2 or 3 year post-period to figure out what happened well after the ACA. And then for some studies, specifically the economic related studies, we use the Oregon Medicaid claims data. All right, now for the juicy part. First question we asked, obviously, was, did the patients get health insurance? Here is the answer to that. Again, that's using community health center data only, so that's not the same as national data. So as you can see, the last two blue bars show a big increase from the 2012-2013 period, where there's about 35% of visits that were insured by Medicaid to 55% in the last two bars, and that's in expansion state. So a big increase in Medicaid visits. There's not much of this increase if you look at the first four blue bars, which are in non-expansion state. And that does make sense. The other thing that this graph shows is that there isn't that much of a difference between the increase in 2014 and the increase in 2015, which suggests that most people signed up for Medicaid right away. The yellow bar are the uninsured visit. And as you can see, there's a decline in both 2014 and 2015 relative to the pre-ACA. And that is true for both expansion states and non-expansion state. But that this decrease is much larger in expansion state. You can see how there's a bigger drop there. The gray bar are private insurance. So again, it makes sense that the first gray bar, for the non-expansion state, there's a fairly big increase in non-expansion, a double in 2014 and then a triple in 2015 on the percent of visit that were covered by private insurance in non-expansion state, and then no such a change in expansion state. So what's the bottom line here? So big surprise, a policy meant to increase health insurance did increase health insurance. That's what we call the DOE science. Here's another study that also looks at health insurance. The study was led by Dr. Larson and looked specifically at private insurance. Here we looked at the change in the percent of visit paid for private insurance, and also the percent of patients who retain their private insurance over time. So as you can see in this graph, as expected, non-expansion state had more visit paid by private insurance than expansion state, again, same as earlier. The percent of visit paid by private insurance does increase over time, which suggests that more and more patients were enrolled in marketplace insurance every enrollment period. What is also very clear here is that there is some kind of a seasonal pattern, especially in non-expansion, where you can see little loops. At every January, it increases and then declines midway through. So patients appear to be timing their care based on when they have health insurance. And that makes sense, and that has been shown. But then, of course, that has implication for continuity of care, especially chronic care management if patients have visit gaps. Also notable into this graph is that despite the removal of the individual mandate and the cost-sharing subsidy, which happened somewhere in 2017, the proportion of private visits did not drop. So that's good. The people enrolled and they remain enrolled. Quiz time. Some said early on that expanding Medicaid was going to lead to a big expenditure and break the bank. What do you think happened to Medicaid expenditure? Did it increase? Did it remain unchanged? Did it increase at first and then stabilize? Or did it decline and then increase sharply? Any idea? Put your answer in the chat. Here is what happened. If you said D, that is correct. What we see here is both outpatient and inpatient expenditure, Medicaid expenditure specifically in Oregon for 3 different groups. So we looked at the patients who were already insured. They already had Medicaid. That's that purple line. Then we looked at those who returned to Medicaid. That is, at some point in the past, they had Medicaid. And then now that there was the ACA, they had Medicaid again. And then that's the red line. And then we looked at the one who gained Medicaid for the first time. There was no evidence that they had Medicaid in the past. So that's the green line. And what you see, so the top 3 lines in this graph is outpatient. So what you see is that there is a big increase in the first 6 months following the ACA. And that's for both the green line and the red line. And that's what we think about a pent-up demand, that patients got insurance and they got their care, their immediate need addressed right then and there. And then it declines to a low level. We also see that the newly insured, that green line, did not cost more than those who were already insured, which is what some were saying. And for inpatients, which are the 3 lower lines, they're kind of bars because we have like the confidence interval there. There's a pent-up demand as well in that first 6 months, but most of these lines are overlapping. Again, this is not showing that these newly insured Medicaid patients are breaking the bank. Oh, another quiz. Okay, this one is about improving access to preventive care. So we knew that was very important part of the ACA. Which preventive service, and by that I mean the percent who would get their A1Cs, their blood pressure, all these ones, which one do you think increased? Is it any of those, all of those, or maybe none of those? I love how you're answering. Some of you know the answers, I can tell. Well, the answer is E. All of the ones that we put there increased, at least in our data. And I will show you some example of those data. So this is colorectal cancer screening. So we look to see if more patients were up to date with their colorectal cancer screening. And that can include either a colonoscopy or a FIT or FOBC, as long as you're eligible for one of those screening. Did you get that screening? So the lighter blue and the orange bar are the pre-ACA period, and the darker bars are the post-ACA period. And it's pretty clear. So you can see that all groups increase in both expansion and non-expansion, pardon me, across all the insurance group. And the largest increase was among privately insured patients. So you can see everybody had an increase. It is a bit surprising, or it was to us, to see that patients who do not have insurance also improve. We have several ideas as to why that might have happened. So one is that, well, community health centers do a great job and they care for everyone, regardless of whether or not you have insurance. Second, those who remain uninsured are more likely to be patients of Hispanic ethnicity. They happen to have higher rate of colorectal cancer screening in our data. So maybe that's an artifact of that. There's also different programs that patients who are uninsured can apply for. And community health centers are great at helping their patients find sources of funding to help them have screenings. Also, the clinics, all of the clinics out there, they do a lot of QI, a lot of targeted improvement, and a lot of outreach. And there was a lot that has been done specifically targeting colorectal cancer screening. So the bottom line here is that for this specific cancer screening, it's a little hard for us to be directly connecting the implementation of the Affordable Care Act to these improvements. So that's an interesting one. Did the Affordable Care Act improve colorectal cancer screening, or was it already something else? We don't know. Here's another study. This one was led by Dr. Bailey and evaluated the impact of the Affordable Care Act on smoking cessations. So here we assess a difference in the attempt to quit. So that's one or more quit status in EHR, whether or not patients who are smoking were provided with smoking cessation medications. And then we also looked at the number of visits because we think that's an important mechanism. These graphs here, they show the specific graph. There's three little lines and dots. So there's dots are the odds of any of these three outcomes of those patients in expansion state that either quit or had an order or had more than 6 visits compared to the patients who were in non-expansion state. Obviously, these are patients who are eligible to fit in this. They have to be smokers. And what we found here, it's pretty clear, it's that patients in expansion state were more likely to attempt to quit smoking. They were more likely to get cessation assistant medications, type of smoking cessation medication, and they also were more likely to have visits. So the mechanism here, we suspect that increase in access to insurance could facilitate the affordability of smoking cessation assistance. They also have more visits, which provide more opportunity to be consulted and receive cessation assistance, which then can lead to more attempts to quit. Okay, so let's stop for a second because that's a lot of information. What have we learned so far? So we learned that increased Medicaid eligibility in expansion states means increase in revenue for CHCs, which is clearly important, and an increase in patient access to Medicaid. Newly insurers clearly had unmet healthcare needs that are now being addressed, and that patients are catching up on preventive services, which is very critical for these underserved patients. That said, did they catch up on this needed care on time or too late? We are studying this exact question right now on a different project among patients with diabetes, assessing acute and chronic complication and whether or not the ACA led to improvement in fewer acute complications or fewer repeat acute complications. So more to come in the future. Quiz time, your favorite. Pre-existing conditions. That was one of my really big topic. I just wanted to throw that over and over and over in the face of the policymakers who are making ridiculous decisions. So what is a pre-existing condition? In case you don't remember, pre-existing condition is a chronic health problem like diabetes that a patient has at the time of enrollment for private insurance. And in the pre-ACA era, these patients would just get denied coverage, or they would have large premium that would make it completely unaffordable because of these conditions. So pre-existing condition was a big deal for the ACA, and it was in the news a lot, and it was in the chopping block sometimes until finally it got it accepted and is now left alone so far. Let's keep our finger crossed. Okay, so here's the big question. Do you know what % of CHC patients who were uninsured at the time prior to the ACA had a pre-existing condition? How many of them had a pre-existing condition? I'll give you a minute. Well, not a minute, we don't have that time. Okay, another 5 seconds. And here are the answers. So as illustrated here, what you see is the % of patients who were uninsured prior to the ACA. So all of these patients that are here all had no insurance prior to the ACA, and they either gained Medicaid or they gained private insurance. The blue bar is the pre-ACA rate of pre-existing conditions. So it's about 65%, and 53 and 52 and 51. So you see on average it's about 50%. Just as a reference, the pre-existing condition in the general population post-ACA is 50%. That's the reference you can keep in mind. Post-ACA, we see an enormous increase. Up to 80% of these patients now have these pre-existing conditions. And this was extremely alarming when the pre-existing condition protection and the ACA were on a chopping block. So this is highlighting again that there was a lot of unmet healthcare need, that these patients weren't able to either go and get the care they could get. They just didn't have the funding and the opportunity to go see their providers, and the critical role that the ACA did in getting these patients health insurance and as a result diagnosed and cared for. We also looked at diabetes and hypertension diagnosis. two of the most common chronic conditions. So this graph here, it shows the percent change in the incidence. So that's new diagnosis of these two conditions. Now, the previous slide was prevalent, so overall, this is new diagnosis. So an expansion is orange and the non-expansion is blue. Maybe you think that's yellow, I guess depends. I always think of it as orange. So you can see again, there's a big increase in diabetes diagnosis in both expansion and non-expansion by more than 25%. And again, that's incidence. And for the hypertension, there was an increase in expansion and a decline in non-expansion state. So that's a little different. So it should be noted here that the big increase in diabetes could be perceived as a decline in population health, right? As now it appears that more people have diabetes, that the incidence of diabetes is greater. And then someone could easily use this information and say something like, health insurance causes diabetes. So we have to be careful on how we write these papers to make sure that no one uses this information the wrong way. But in fact, here again, we're seeing unmet healthcare need, patients who couldn't get the care they needed. And since we did find that there was an increase in preventive care, including A1Cs, then it makes sense to see increases in diagnosis. Lastly, we looked at mental health and substance use diagnosis and found again very large increases among those who gain insurance, especially Medicaid post-ACA. Again, this is the same group as earlier, patients who didn't have health insurance at the time prior to the ACA, and then they gain Medicaid or they gain private, and then now they have this large increase in their prevalence of both mental health and alcohol and substance use disorders. So what these bars shows, if you just look at the Medicaid group, is that pre-CA 34% of uninsured patients who had a visit had a mental health diagnosis. Post-CA, now it's 46% of the same patients. Nearly half of them had a mental health diagnosis. This was true both in expansion and non-expansion, so I'm not really showing you that here because that's too much information. But the bottom line here is that regarding chronic conditions, access to health insurance and preventive care following the ACA led to many patients being diagnosed with conditions which clearly they were dealing with prior to the ACA. Quiz. Okay, do you know what percent of cancer survivors receive, sorry, let me try to start over, were seen in CHCs that were uninsured prior to the ACA? So here we're talking about cancer survivor using the typical definitions, but of someone who has a cancer history or diagnosis of cancer on their HR, and they're in CHCs, and what percent of them are uninsured prior to the ACA? Put your answer in the chat. You're right. The answer is C. So that's the red area highlighted there, uninsured, that first little box. And it shows 20 to 30% of cancer survivors were uninsured prior to the ACA. I think that's enormous. And this study found that there was a substantial decline in the uninsured visit among cancer survivors in Medicaid expansion. They went from about 20% to 6%, which is great. As expected, we see more cancer survivors are insured with Medicaid in expansion state, with an increase of 15%, and more privately insured cancer survivors in non-expansion state, with an increase about 11%. That makes sense. That said, at the end, there's still 1 in 5 cancer survivors living in these states, especially the one that did not expand, that remain uninsured, which is still enormous. We also look at diabetes control using A1C level. Now, this graph has a lot of information in it, so I'll try to summarize it. So we wanted to know whether gaining health insurance led to better control of diabetes. you did your biomarkers, you get tested, we had A1C results, and did it change over time? Now, it's hard to change your A1C result. This graph shows the percent of patients that have diabetes that were under control over time. The blue line is the newly insured. What you see here, the blue line is always below the other lines. So the newly insured managed to have, they were overall better, they had better control of their diabetes. They were also doing it faster, which is what this hazard ratio number is. And they did it better than those who were continuously insured, any of the other group, but also those who are continuously insured. You can also see that the red line and the other reddish line, which are the top two lines that are overlapping, those are the continuously insured and the discontinuously insured. And they continue to do worse. So clearly more needs to be done. Okay, let's have a little small intermission so you can digest some of that. Think back in the days before COVID, if you can, after the ACA, what were you seeing in your clinic? Or what was your experience as a patient? Did you see improvement in chronic disease management? Did you see cancer survivors that were uninsured? And how could you help these patients? Did you notice a rise in mental health and behavioral health need? Now in the COVID era, do you notice a change in mental health needs? And does the ACA continue to help? Think about that. Feel free to put comments in the chat and your reflections. I'll give you 10 seconds to think. That's it, moving on. Okay, so one element we're also particularly interested in evaluating is whether or not the ACA did reduce health disparity, which it was aimed at. So here we wanted to know whether the gap in insurance access between different race and ethnic groups were eliminated and at least reduced. So here you see change in uninsured visit among patients of white or Black race and those of Hispanic ethnicity. So Hispanic ethnicity is the blue line, the orange is white, and the gray is Black. And this is visit rate over time. The line, the vertical line indicates the ACA. It's slightly off, but it's supposed to be 2040. So looking at patients of white and Black race in expansion or non-expansion state, so there's the two panel there, we don't see a lot of difference in the rate of uninsured visit, whether it's pre or post. They're not fully overlapping, but they're really, really close. But there's a big gap compared to the patients of Hispanic race. That blue line seems to have quite a bit of a gap. That were more likely to be uninsured by about 10 percentage point in non-expansion and 20 percentage point in expansion state. Well, it's visit rate, so it's 20 visit rate. So you can see that the gap is not really narrowing. So everybody's improving post-ACA, everybody that is, fewer patients are uninsured, but that gap isn't really changing. And in expansion state, we see a larger decline again, but not for patients of Hispanic ethnicity. So one could say disparities, not so much. Let's look at Medicaid visit. So again, this is the idea of Medicaid insured visit, and we see what we expect, no change in non-expansion and increase in expansion state. And again, that blue line, they improve, but the gap between the blue line and the other does not seem to be reduced. And in this one, there is a little bit of a decline in the gaps between the orange and gray lines, so that is white and Black in expansion. The gap increases in non-expansion, but the blue line really doesn't seem to improve in terms of the difference between these three race and ethnic groups. And here's privately insured. So here, same as as I've said multiple times already, non-expansion state have an increase in number of visits that are insured by private insurance, and in expansion, it doesn't really change. But here, though, we see a reduction in this gap for patients of Hispanic ethnicity, that actually they exceed the number of visits that were privately insured in non-expansion states. So it seems like private insurance did benefit Hispanic population, and there is a reduction in the gap. Of course, marketplace insurance is not the, it can be very challenging with this high deductible issue. But the bottom line of these three slides is that there was a lower rate of uninsured visit for all racial and ethnic groups. That suggests progress, but that this progress is not uniform. And when comparing expansion with non-expansion state and among all racial and ethnic minority subgroups, we find continued disparities, that this change in insurance access was not equitable and did not eliminate insurance disparities. Now, recently, both California and Oregon have expanded their Medicaid program to include adults, regardless of immigration status, which may benefit the Latino population. Now, California is not as comprehensive as Oregon, but still that could be something that helps a little. Here's another look at disparities. Here we assess diabetes control by race and ethnicity again. And then this figure shows the average A1C pre versus post ACA. So the numbers are actual A1Cs, and the lines shows the different insurance groups that each of the race and ethnic groups were. So first we can see that having continuous insurance is associated with better A1Cs. That is the blue line, which is always lower than the other line. That seems good. Changes from pre to post ACA were relatively similar across the different groups. There's some differences. For example, the newly insured Hispanic, which is the center panel, and that's the green line. You can see that it has a largest decline in mean A1C, which reinforces the importance of increased access to insurance for this population. So it's really clear that we need to do more to help these patients gain insurance. Now, I want to say that these effect sizes are small, but they are population average. So moving the needle a little can be very impactful. This one, look at cancer prevention, again by race and ethnicity. These results shows that the prevalence of cervical cancer screening were very similar across the two race group and ethnicity. And they are a little higher for non-white, either Black race or Hispanic, and an increased post-ACA for all groups. And then in fact, the risk for cervical cancer screening was often higher among Hispanic patients, especially post-ACA. This is a testament to CHCs and the work they do in reducing disparities in cervical cancer screening. Okay, so another thing we looked at was neighborhood characteristics. As you know, social determinants of health is a big deal, and where you live matters. And we were like, well, maybe patients who lived in really deprived areas improve better, or maybe it didn't work for them, the ACA. We're just curious, we had to look at it. So this graph is the probability of patients of having hypertension controlled by insurance group, and we compare those who lived in deprived neighborhood, that's the right panel, to less deprived neighborhood, that's the left panel. Each line represents an insurance group. Here, the neighborhood deprivation is assessed by an index that combines many different indicators for social and economic health, like poverty, unemployment, things like that. And then you can see on the right that those living in the most deprived neighborhood who gain insurance, that blue line improved the most. This is the gaining insurance group, and it says that the probability of these patients of having their hypertension in control went from about 50% to nearly 70%. That's a pretty decent increase, and the difference was just that they lived in more deprived neighborhood compared to others. So that says that getting health insurance is related to hypertension control, but it also matters more for patients who lived in the most disadvantaged communities. All right, so what did we learn over the years? We learned that we can produce evidence for the obvious. I know that seems pretty sad, but we have to keep hammering that information apparently. So we did see that policies that are aimed at increasing access to health insurance did just that. That's good. We also did see that this was not uniform and that inequities remains, especially among patients of Hispanic ethnicity. So we know that more needs to be done to be achieving health equity, which is such a priority right now. What we showed, though, is that you really need to take a deep dive to not only just show the positive impact on the multiple different levels and outcomes, but also the remaining gaps. The results are pretty clear that some groups did not benefit as much, notably patients of Hispanic ethnicity, while others, policy was very beneficial, mainly those who gain insurance and patients with chronic disease. And that even among this population, of mostly patients who have low income, where they lived mattered. So what is next? As you're very much aware, the pandemic created a new set of uncertainties. There were a lot of jobs lost at the onset, a lot of people that enrolled into the Medicaid program. But what about those who lived in non-expansion state? How are they going to be receiving their care? Event that coincided with the pandemic brought forth a lot of inequities, structural racism, and the need for more to do more to achieve equity. So it's a really present topic in right now, and I feel like this could make a difference. Oregon, for example, is starting to talk about universal health care. President Biden is talking about lowering the age of Medicare, which is not a new concept at all. Oregon and California, as I said before, have expanded their program to be more inclusive of patients regardless of immigration status, which is something I plan to evaluate next. So there's a lot of changes locally and nationally that are continuously happening. So more to come. So I just want to thank everyone that over the years have participated in this adventure. Thank you. That has been a big team and continues to be a big team. I want to thank the Health Center for sharing their data and making this evaluation possible. Thank you. And I want to thank you, and I'm happy to answer your questions. And in case you're wondering who is going to win the quiz, you are all winner. Because
thank you so much, Dr. Huguet, for that insightful and fantastic presentation. And thank you to everyone who attended today's session. Follow OHSU Family Medicine on Twitter at OHSU Family Med. That's at OHSU Family Med. And be sure to follow OCHIN on Twitter at OCHIN Inc. and over on LinkedIn. In addition, head over to OCHIN.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And don't forget to visit our OCHIN YouTube channel to catch up on our past Grand Rounds presentations. And OCHIN Grand Rounds will be taking a break for the month of August to get ready for our Season 7 premiere, where we welcome Dr. Mark Sendak and Suresh Balu of the Duke Institute for Health Innovation as they present on artificial intelligence and machine learning, also known as AI/ML, in healthcare. Invitations to this presentation will be sent 2 weeks prior to the event, but if you are not on our mailing list and are interested in attending this or any future event, please email me at grandrounds@ochin.org. That's grandrounds, all one word, grandrounds@ochin.org. So from all of us at OCHIN and Dr. Huguet to all of you, have a wonderful rest of your day and stay healthy out there.